to Abnormal Behavior. I am Dr. Anupam Agarwal. This educational initiative is brought to you by Clinics India, GP Clinics, and DockersLive.com. Friends, as you know, GP Clinics is our flagship journal being published every month for last 15 years. I thank all our readers for giving an overwhelming response to GP Clinics all these years. Friends, the recordings of all the previous webinars are available on our website gpclinics.in and on our YouTube channel dockerslive.com. Also, the summary of each webinar is published in GP Clinics print edition every month with answers to all the questions you ask in the chat box. Dr. Y.K. Amdekar is speaker for today's session as usual. And just for the information of readers, the Dr. Y.K. Amdekar is having fever today and he has taken a crocin tablet, and it shows the commitment he has towards educational programs. So over to you, Dr. Amdekar.
Thank you very much, Anupam, and good morning, friends. I think today's topic is not something normal that you see with physical complaints, but I'm sure it is getting more and more prevalent over the years. And I thought this is a topic that we all must kind of be able to address. And that's why I've chosen to speak today on approach to abnormal behavior. Can I have the first slide, please? Now, you know that is abnormal behavior a disorder? Well, many of us behave abnormally at times. Okay, politicians have been behaving abnormally every day in our Lok Sabha, Vidhan Sabha, etc. Do you think it's a disorder? So now we need to be very clear as a doctor. We need to pick up abnormal behavior as a disorder or whether it's a situational behavior of a person who has no control over his mind. In other words, a very consciously wishful abnormal behavior is not a disorder. But somebody is behaving abnormally but is not even aware of it. And that's what happens when there is a deviation from normal expected behavior, which is a maladaptive behavior, which means that he is not able to adapt to the environment the way a normal, fit adult should be able to, or a child should be able to. And I think this kind of a behavior, which is not under his control of will or wish, but it leads to functional disability in daily life, many times harming self or harming others. And I think we are all clear that while each one of us may behave abnormally at times, it is not subconscious behavior. It's a very conscious behavior. That's not the disorder. That's your choice of behaving badly. And it cannot be called a disorder. Having made this very clear, there are two types of largely abnormal behavior that we see in clinical practice. One is, of course, an acute change in abnormal behavior. What I mean is that there is suddenly a change in the behavior of a person who was reasonably normal just maybe a few minutes or a few hours ago. This happens often in an acute sickness or acute illness where some way the brain is getting involved. And that's why the behavior is the first change, even much before a patient becomes unconscious or throws a convulsion. And I think this kind of an early encephalopathy. What is encephalopathy? Just it means that an encephalon is becoming pathological. Now, this brain cortex needs blood supply, it needs oxygen, it needs all metabolic products. And if there is anything going wrong with this, like hypoperfusion, hypoxia, hypercarbia, hyponatremia, whatever, I think you start getting an acute change in behavior, and there could be many, many underlying causes, and we'll discuss some of them with the case scenarios. But I want you to understand is that a simple viral infection that we all see commonly day to day and is expected to get better within a day or two could land up on day three with a child who is a bit confused, a child who is behaving a bit as if he is not fully aware of what he is doing, indicates often a complication. And I think you need to pick up this acute change in behavior. I will dilate on this a little later. But there are other abnormal behaviors which are the sole or a major presenting symptom, and they are due to neurodevelopmental disorders. Something is going wrong with the nervous system development. It could be genetic or syndromic. It could be neurodegenerative, as happens naturally in old age, but could occur at any age, even in a young child, because of a progressive neurodegenerative disorder. And then the third type of a chronic disorder is a mental diseases, where a person behaves inappropriately, deviation from the normal behavior. Well, early manifestation of abnormal behavior could be simply undue irritability, restlessness, carelessness, forgetfulness, are all possible symptoms of something that is evolving, and one must pay a lot of attention to these small little changes in behavior that occurs. Well, there is an increasing prevalence of especially mental disorders in all age groups. And we are aware that 30% or more of the adult population today has a depression, as a mental disorder, and it presents with a behavior change. Well, what is important of all this is if we suspect early enough, then possibly the management, prevention, and the outcome can very much be a bit different than otherwise. And I thought that's important to discuss an abnormal behavior today. Can I have the next slide, please? Now, the next slide again tries to impress on what could be the manifestations of an abnormal behavior. I already told you that in an acute simple illness of any kind, if there is a sudden change in behavior, a significant change, such as a patient becomes lethargic on a day when his fever is disappearing, or he looks confused, or he suddenly becomes irritable. Well, fever is getting better, so probably the viral infection is getting better. But why is he getting a sudden change in behavior? And this could be an early symptom of a complication that is likely to ensue, as typically happens in today. To the slide. I have not asked for a change. Back to the slide, please. Yes. So, it is in a dengue fever, you start getting fever and severe body ache, etc. But over 2, 3 days, the fever gets better. And by the time you feel that the patient is getting better, suddenly the patient looks confused, patient looks a bit drowsy, irritable. Be sure this child or this patient needs a hospitalization because he is developing what is known as the capillary leak syndrome. He is getting hypoxemic, he is getting hypoperfusion of the brain. And if you miss this, he will become more and more drowsy, he may become unconscious, and you may lose life. Whereas the management can be as simple as just giving intravenous fluids. This is a simple example of what we all see, and what I want to drive at with this kind of an acute change in behavior is even the simplest of the simple illness Please follow this over a week or two to make sure that there are no complications. Today we know that a disease like COVID, viral infection, can develop complication even after weeks or months. And therefore, today we should be very, very alive and watchful to such sudden change in behavior. Having said this, as I mentioned earlier, the chronic changes are very, very common and first and foremost important in children is a neurodevelopmental disorder like an autism spectrum disorder. Friends, today we see autism spectrum disorder fairly commonly in the normal population at all levels. And I think such a child presents with a defective social interaction or communication, and he has a very restricted repetitive behavior pattern. What it means is when you call him, he doesn't look at you, and you feel that he is in his own world, engrossed in his play, but that may not be so. It could be the first symptom of an autism spectrum disorder. He is not able to communicate well, and therefore many of these children present with a delayed language development, and they don't speak even up to 2 or 3 years of age, and then they come to us to find out why the speech is not developed. And they have an extremely restricted interest in every activity. For example, if they back to the slide, back to the slide, back to the slide, yes. If you find that uh, a child is interested only in one play with one toy and he doesn't like anything else at all, he has a very restricted behavior choices. He likes only one type of food. He likes only one type of consistency of food. Anything else, he would reject and he will throw a temper tantrum. I think this is maybe an early symptom of autism spectrum disorder, and pick this up as an early change in behavior, which is very important. It is deviation from normal. A normal infant or a toddler is tremendously interested in exploiting the world around. And if this child has no such interest and is just playing with one toy all the time, I think that's abnormal behavior. Similarly, another type of a neurodevelopmental disorder is an ADHD, that is like an attention deficit hyperreactive disorder. It's a bit different than autism because this child has an inattention but also has an hyperactivity and impulsivity. He has a lot of interest in multiple activities, but he does not sustain interest in any particular activity. And he also does not attend to anything. He is forgetful. He is not doing well in school. And all these could be neurodevelopmental abnormalities. We need to pick up this early. And today we pick up autism or an ADHD as early as 12 or 18 months of age. And then only there could be a good outcome of a proper therapy. Of course, another kind of an illness is the neurodegenerative illness, and you know it presents as dementia, for example, and an extreme stage of dementia could be Alzheimer's, where you just don't perceive anything at all around you. I think dementia is getting fairly common and manifests as change in behavior, which means you don't feel motivated, you don't feel initiated, you have no interest in life, you have no interest in any activities, you feel homeless, you feel sad. I think these are the symptoms that you pick up early and try to settle and send it to an expert to take care of it. And of course, there could be a mental health disorder as well. Depression, as I talked to you about, feeling sad, low esteem, anxiety disorder. Today, anxiety disorders are also becoming common in children, and we see children with a recurrent abdominal pain, recurrent headache, whatnot, which is all due to stress or anxiety, and these need to be also picked up fairly early They are not easy because they almost simulate a genuine physical illness. Can I have the next slide, please? Next slide, please. Now, next slide discusses a simple clinical approach. And the first step is to be sure whether there is any acute onset of a change occurring and look for hidden symptoms. And of course, there could be a chronic problem as well. And a good history can make sure whether it's really an acute change in behavior due to an illness which needs an urgent attention. It could be life threatening. On the other hand,
Good कैसे करो? हाँ,
I'm I'm sorry for this kind of a thing beyond my control.
no issues, sir.
And therefore, we were talking about the clinical approach. And the first thing is to rule out a physical problem that is causing an acute change. And that's quite a serious problem. And a good history and a physical examination will always guide to see whether there is any neurodegenerative or a neurodevelopmental disorder or a mental disorder. I think physical illness is what you can exclude easily as a change in behavior, and that's an emergency often. But if that is not so, then I think it's the time for most of us as general physicians that this abnormal change needs to be picked up very early and referred to a particular expert so that they can take care of all such problems. We are not experts in dealing with such problems in general, be it an autism spectrum disorder or be it an inattention and hyperactivity disorder in children, or maybe a dementia, or maybe a depression. All this needs an expertise. And as a general physician, our duty is not to miss an acute behavior change as a complication of a physical illness, which could be life threatening. And two, if that is not so, and if it's one of the chronic neurological problems, neurodegenerative or developmental or a mental health problem, then most early referral is likely to come out with a better outcome. It's not easy for a patient to accept that they have one of these disorders, but you need to counsel them and kind of convince them that there is a need to see a psychiatrist or a psychologist for better evaluation. And I think this is an important part of all of us as general physicians. And I thought this is an important problem. Today, these problems are on the increase, and we need to be very aware of it. Don't disregard it, but pick up very early. Having said all this, let's do as usual different types of cases with voting. Can I have the next slide, please? This is the first case where a healthy adult presented with high fever, severe body ache and headache for 2 days, followed by a confused state of mind And on direct questioning, he had not passed urine for 12 hours. On physical examination, he had mild fever, but he looked very confused, but responding to commands, no localizing signs. Now, your options of diagnosis are: could it be early meningitis, early encephalitis, impending shock, or any of the above? Your time starts now. I think majority of you have said it's a it's a 50-50. Impending shock and encephalitis, and now we have any of the above equally 40% encephalitis. Nobody wants to call it meningitis. Well, that's fine. Let's get back to the slide. I think if it was a meningitis, this is an adult, he would have started with fever, and a day or two later, he would have started with headache and vomiting, and would have
To
meningeal
abnormal
signs
behavior.
like a neck
I am
rigidity,
Dr. Anupam
etc.
Agarwal.
But he would not
This
feel
educational
confused.
initiative is brought to you by
Confused
Clinics
means
India,
an
GP
encephalon is
Clinics,
involved.
and
In
DockersLive.com.
bacterial meningitis, in a healthy adult, you do not have any problem with the brain function unless you have delayed the diagnosis of meningitis, and now that meningitis, because of increased intracranial hypertension, has started affecting the cortex as well. But therefore, there is not meningitis. Could it be encephalitis? Now look at what has happened. That this confused state came after 2 days, but in an acute encephalitis, the CNS manifestation come almost within the first 24 or 48 hours, and these manifestations are in the form of drowsiness, unconsciousness, seizure, convulsion, and therefore this is not encephalitis. But those who opted for encephalitis are very close to the correct diagnosis, and therefore you could have said this is a slowly developing encephalopathy. Encephalitis is an acute onset inflammation, so it runs fast and it causes a drowsiness, unconsciousness, convulsion very early in the course of illness, whereas this has come up a little slowly. First is a cerebral manifestation has come up after 2 days of fever. In encephalitis, it would have come in first 24 or 48 hours itself. And it would have come in a very big way, unconsciousness, convulsion. Whereas this shell is just showing a very early encephalon involvement. And therefore, the correct diagnosis is an impending shock. This child is getting hypoperfused. This child is getting probably metabolically deranged. And if you allow him to go further, this was typically a dengue fever, which I talked about in our initial discussion. And as he was getting better on day 3, he started developing a capillary leak syndrome. And all that he required was a push about a liter or two of intravenous fluids over 12-24 hours, and he would just come out beautifully. But if you miss this, then he would proceed to be unconscious, may have a seizure, and may have a problem of managing this with probably a poor outcome. Friends, I told you that anything that happens in an acute illness, change in behavior is a complication, and this is an impending shock. Can I have the next slide, please? The next case, please. Next slide, please. Next slide, yes. Now, this is a senior citizen presented with an acute onset of sleepiness that worsened over the next 2 hours, when he developed a seizure. Make a note, he starts with feeling drowsy, sleepy, then gets worse in the next 2 hours, developed a seizure. Physical examination revealed drowsiness, but responding to painful stimuli, paucity of movements of the left upper and lower limbs. Your probable diagnosis is it an intracranial hemorrhage? Is it a subdural hematoma? Is it an arterial infarct? Or is it a venous infarct? Your time starts now. Start the time. The house is fairly divided, but nobody has opted for a venous infarct. Okay, back to the slide, please. Now, had it been an intracranial hemorrhage, it could have been much quicker, it could have been much widespread in one area or extensive area, but not just a left upper and lower limb paucity of movements, which means that there is a localized vascular lesion. When you have a localization to a particular site, and in this patient, the localization is to a left upper and lower limb, which means that the middle cerebral artery in the internal capsular lesion has caused a vascular problem. So it is not an intracranial hemorrhage, which is not so localized to one vessel. It is not a subdural hematoma again for the same reason. And therefore, either it is an arterial infarct or it's a venous infarct. Now, you get the point what I mean, that if there is a clear localization of a fairly acute onset within 2 hours, then it is likely to be a vascular episode, or we could call it a stroke. So this is a stroke. Now, whenever there is a stroke, it's either arterial stroke or a venous stroke. And what is the difference? Arterial stroke in a particular lesion, like in this patient, a typical middle cerebral artery has had a stroke. There will not be any change in the behavior, drowsiness. There will be simply a sudden onset of a paucity of movements. There will not be any lasting encephalon involvement because the encephalon is not involved. It's only one area that is supplied by the middle cerebral artery is involved. But when it's a venous infarct, then because the venous drainage is obstructed, the entire cerebral cortex starts getting disturbed, dysfunctional, and therefore the difference between an arterial infarct and a venous infarct is arterial infarct has no significant changes of a brain cortex involvement, whereas a venous infarct presents with drowsiness, unconsciousness, whatever. And I think this was there for a venous infarct. I just wanted to also, by such change in behavior, also learn something about the physical illnesses that could cause change in behavior of an acute onset. And the previous slide told you how a capillary leak causing a hypoperfusion of the entire brain cortex was presenting as a confused state after a febrile illness. And this shows in a senior citizen a sudden stroke, which is a venous stroke and not an arterial stroke. Again, friends, I want those who attend such kind of webinars to think at a higher and a better level. And I'm sure that those who participate in such academic program have urged to do better and better. And from that point of view, I bring sometimes cases which kind of enlighten you, and you may be doing much better than earlier. Can I have the next slide, please? The next slide, please. Fine. This is a 15-year-old child presented with fever, breathlessness, and mild cough for 3 days. Diagnosed as bacterial pneumonia. Child is stable. Okay. Under treatment. His saturations were 95%, slightly lower than expected. Antibiotic was started, and 2 days later, mother noticed that he could not recognize her, though she was standing next to him, though he was fully conscious. When asked, "Where is your mother?" he could just look around, searching for the mother, when the mother was right there. Abnormal behavior of a child of 15-year-old who is being treated for pneumonia for last 2 days. Your actions could be based on the correct diagnosis. Your actions could be start oxygen and observe, upgrade antibiotic and observe, or do CSF and CT scan to decide further action, or simply an upgrade antibiotic. Your time starts now. Can we have the slide back? Now, we need to think why this sudden change in behavior has occurred. Well, if the illness is worsening, like you have possibly now pneumonia has developed also meningitis, then only you will consider CSF or CT scan or whatever. Again, CT scan is not necessary at all to diagnose meningitis, but CSF could be. Friends, remember that it's extremely rare. Well, in medicine, everything is possible, but it's extremely rare to have a patient of pneumonia develop meningitis or vice versa. In fact, when the bacterial infection has been localized to one area, it's a clear indication that the patient is not allowing this bacteria to disseminate to other sites. He has been successfully localizing it to one site. And therefore, pneumonia and meningitis don't go together. Besides the fact that meningitis does not come with just a problem of a change in behavior. We said in an earlier slide that meningitis comes with headache, vomiting, if at all irritability, but not recognizing mother. What is not recognizing mother is again a brain cortex is involved. And in meningitis, brain cortex is not involved unless it is a late stage and a mismanaged patient. And therefore, there is no question of doing a CSF. Why should we upgrade an antibiotic? Because the child is stable. Now, if the child is stable, then we don't want an antibiotic to be upgraded, because if that was so, the child would start running more and more fever and would get more and more toxic. Therefore, this child has a hypoxia, and therefore he needs just oxygenation and observe. When you start oxygen, within about 20 minutes of a good oxygen therapy through nasal prongs, this child started feeling better and could now behave well. What have we learned? Acute change in behavior is often immunological, like a capillary leak syndrome. It could be also due to hypoxia or hypoxia or hypoperfusion. And I think these are the examples I wanted to stress in acute change in behavior. Don't ignore them. They are life threatening and they could really get us into trouble if we overlook it. Many times, when somebody is behaving a bit abnormally during such acute illness, one tends to ascribe it to, oh, he's sick, so he may be behaving like this. But no, nobody behaves abnormally because simply of a sickness, and an abnormal behavior suggests that the brain is not functioning as it should be. So, these three cases gave you an idea how an acute illness also should be watched carefully for any behavior change. And I will repeat once more a statement that a sudden change in behavior in any acute illness is the first step telling you that he is getting some complication. What complication we may not know just by that. It could be metabolic, it could be immune related, whatever the cause, but it needs a very close attention and often even hospitalization. Can I have the next slide, please? Now, the next slide is a middle aged adult who was seen to behave abnormally in a family gathering, and he suddenly slapped a guest for no reason. Now, that's quite unusual. You can't slap a guest in your family functions. But he has a past history of loss of appetite, abdominal distension, and edema of feet. Take a note. He's not a normal adult. He has a loss of appetite, abdominal distension, and edema of feet. So obviously he has some chronic illness. And this fellow, having a chronic illness, suddenly behaves abnormally, slaps a guest. Okay, what must have happened to him? Your choice is developed a stroke, he has a mental disorder, or he has a degenerative brain disease, or he has a metabolic disorder. Your time starts now. Can I have the slide back? No more discussion. All of you are perfectly normal, perfectly fine. I'm so happy. And this loss of appetite, abdominal distension, and edema of feet mostly is a chronic liver disorder. And the first symptom of a liver failing or a liver cell failure is a change in behavior again. Friends, if we miss this, he would go on to develop jaundice, encephalopathy, or a hemorrhage, and a classic liver cell failure symptoms and signs. But an earlier symptom could be a change in behavior. And what a change in behavior! An abnormal behavior, slapping a guest. This is a real case. And a good clinician picked this up and said, oh, you are likely to develop a liver cell failure, you better get hospitalized. And surely his enzymes, his liver function test, everything is suggesting that he was likely to get into trouble. He had a bit of hypoglycemia, he had an hyperammonemia, all metabolic changes of a chronic liver disease getting into liver cell failure. What a simple abnormal behavior telling you, oh, there is something happening. In the earlier three cases, we discussed about abnormal behavior of a sudden out of either a vascular or a hypoperfusion or a hypoxia to the brain. And this is a chronic illness also coming with an abnormal behavior of a sudden origin. It's a metabolic disorder. I'm very happy you all picked it up so well. Can I have the next slide, please? Next slide, please. Now, this is the middle-aged woman who suddenly felt uncomfortable, developed palpitation and excessive sweating, which lasted for 4 hours. Physical examination at that time showed she was restless, her heart rate was 120, her blood pressure was fine, and rest of the examination was normal. What's the probable diagnosis? Myocardial infarct, rhythm disturbance, hypoglycemia, or none of the others. Your time starts now. Back to the slide. Can I have the slide back? Well, you all rolled out very correctly myocardial infarct and rhythm disturbance. Hypoglycemia typically is an acute onset problem, barring an exception. Whereas this child did develop acutely, but what is happening is this person has no reason to be hypoglycemic unless there has been a diabetes missed totally, and because of that, she is getting into a hypoglycemia because he would have got hyperglycemia at that time. And if she was already diagnosed diabetes and she was using a wrong management, she could be hypoglycemic as well. Okay. We have not said that she was starving or anything. Okay. So this is likely to be none of the above. And what was this? Simply a depression. Okay. The depression manifests like this. Okay. A fear of something, stress of something. Okay. And this is typically what a child of a mental stress or of anxiety starts coming up. Okay. Causes could be many, but typically an anxiety disorder which presents with an autonomic nervous dysfunction, which presents typically as sweating and palpitation. And this could be out of many reasons, but commonly an anxiety. Well, there could be underlying depression, whatever, but even a fear of something, anxiety. For example, somebody who is going to face some difficult situation has an anxiety because of that, could develop something like this. And therefore, this was an anxiety induced autonomic nervous dysfunction. It lasted for a long time. Hypoglycemia would not last for a long time. Either it would go on worsening and throw up a seizure, or would correct itself by the natural defense mechanism. And that's why this was an anxiety disorder. Can I have the next slide, please? Next slide is a 2-year-old presented with inability to speak and not responding when called. He likes to play the same game, wanted same type of food always, would not sit at one place except while watching TV or using cell phone, and could sing a song. Other milestones were normal. What is your probable diagnosis? Mental retardation or deaf and mute, mental disorder, or a neurodevelopmental disorder like autism spectrum disorder. Your time starts now. Back to the slide. Back to the slide. Excellent. It's a typical autism spectrum disorder. Friends, don't miss this. Today we can diagnose, not diagnose, but suspect even much earlier in infancy. For example, a 2 or 3 month old child has an eye-to-eye contact with the mother when the mother is talking to this small infant. If this baby of 3 month old, when the mother is talking to this baby, does not look at the baby, you need to worry whether his vision is abnormal or his brain is abnormal. Okay. And when the mother talks to this baby, if the mother does not have eye to eye contact with the mother, also worry whether there is any hearing impairment. So, when there is no such eye to eye contact, or as the time goes, there is no language development, like when a 3 4 month old does not have eye to eye contact, and by 5 6 months, when somebody calls, the child does not look at that person calling, or when there is a sudden noise, he does not look at that sight of noise. I think it's indication that either he is hearing impaired, check the hearing, and if his brain function and hearing is normal, then you have almost suspected calls the autism spectrum disorder. Friends, today it is very, very common. And this disorder is due to a genetic defect. But why did I not see this kind of disorder, say, about 20 years ago? And if we had missed it, then we would have seen many older children and adults behaving abnormally, which we did not. So I imagine, though it is a congenital or a genetic defect in the brain, but it needs a comorbid environmental problems. And what is an environment problem which did not ever was present 20, 30 years ago is very commonly present today. And that is no time for anybody to talk to a child. When 30 years ago, or when I was a small child, I was in the midst of a large number of people. There was no cell phone, there was no TV. We had to talk to human beings. We had a social interaction. Today, in the last 20 years and more, as the years advance, today we find there is both parents go out to work, some helper looks after a small kid, and all that she does is to feed the child and put him to sleep, but there is no interaction. Lack of social interaction. And then what does this small baby do? He keeps on playing on the cell phone or watching TV, and therefore he only knows to look at the inanimate objects, and inanimate objects do not need interaction socially. Therefore, he starts having no social interaction, and his genetic defect starts manifesting because of the environment. Friend, this is very important. We have now evolved, we have advanced. And what does advance and evolution mean to us? Even in India, we are away and away from the families, from the community. Earlier, we used to stay in a chawl with everybody's house open doors, everybody moving into anybody's house. It was a big family. Today, it's not only the flat system where you don't know who is staying in the next flat, and even in the same flat, a child has a room, the parents have a room, child has a TV in his room, child has a cell phone with him. There is no social interaction. Parents have no time, and the child is busy with cell phone and things. Today, we are very clear that we should not allow the young child, if possible up to 5 years, to handle cell phone or to watch TV. But watching TV for a good program along with the parent may be acceptable for about 30 minutes because there is something to learn from that. But don't give a cell phone in the hand of a child. If he has got a mild genetic defect, you will bring out a fully developed autistic child. And I think this is a message I want to give strongly, even for a social purpose. Can I have the next slide, please? The next is another young child who is presented with poor school performance. He is disorganized, he is forgetful, he is careless, he loses objects, he is not able to complete his task, he has difficulty in following instruction, he is hyperactive and impulsive, but he is very intelligent, he has a good memory, he talks to people confidently, but this is his behavior. What is a probable diagnosis? He has an intellectual disability, he has a learning difficulty, he has a mental disorder, or he has a neurodevelopmental disorder. Your time starts now. Start the time. Can I have the slide back? Intellectual disability is out. I said that he is very talkative, he is intelligent, his memory is good. Okay, but he has a poor school performance, even with a normal memory and normal intelligence. He may have a learning disability or difficulty, but a child with a learning difficulty does not have an abnormal behavior like he's hyperactive, impulsive, he's careless, he loses objects, he's forgetful, he's disorganized. Therefore, he has the neurodevelopmental disorder, and this is what exactly is an inattention and hyperactivity disorder. Okay, this is another kind of a neurodevelopmental disorder. It also must be picked up very early and it has to be managed with therapeutic measures with a better outcome. Can I have the last case? Next case, please. And this is a middle aged, successful woman, executive, who's getting irritable and intolerant to her subordinates, finding difficulty in making decisions, feeling guilty about her performance, was losing initiative, feeling hopeless, and had low esteem. What's your probable diagnosis? Neurodevelopmental disorder, mental disorder, systemic hypertension, or a metabolic disease? Your time starts now. Can we have a slide back, please? Excellent. This person is depressed. The previous person had an anxiety disorder. Okay, which could have come out of many other reasons, but it's typically an anxiety manifestation of a sudden sweating, okay, palpitation. Whereas this person has a depression for whatever reason. And I think this needs to be picked up very early. Moment this person gets irritable, her subordinates would say, Madam was never irritable like this. There is some change. This change needs to be picked up. And even the family members would feel the same. I think I spent a lot of time on such discussion because the next slide, please. I don't have to much talk about investigation because there are hardly any investigation of that kind of a CT, MR, blood test, etc. required, except for an acute change where it has to be left with a ICU people or for further management. The investigations are not a kind of a laboratory investigation, but a detailed analysis of the mind, and that is best left for the experts. The next slide, please. And the next slide also. The next slide, please. The next slide, please. And therefore, management is again not our problem. I will just end up with saying that behavior change in an early symptom of encephalopathy. And we have said don't miss it on an acute illness, but also don't miss on a chronic problem. And I think as a general physician, our job is to pick up early change to save life of an acute illness patient and also to save the outcome or improve the outcome for a chronic problem, but pick them early. I think I will stop at this point of time. I have not spent any time in investigation and management because there was no need. If there is some time, Dr. Anupam Agarwal, we can take a few questions.
Yes, sir. Thank you, sir. The first question, can irritability be considered as abnormal behavior?
Come again.
Can irritability be considered as abnormal behavior?
Oh, yes. Oh, yes. The point is, again, it should be an acute change. And by acute change, I don't mean in hours. I mean in some days. Oh, last 1 week, this person looks irritable for no reason. And he was never like that. He was very nice. He was very happy. And I think this change is often felt by the family members. They don't come forward often to us, but we must be alive to that. And to that extent, yes, irritability of an acute onset is the illness, like an increased intracranial hypertension, meningitis, whatever. But if it lasts for a week, more so in a person who was never like this. Sir, he was a very happy and nice fellow to behave with. Nowadays, he is irritable for no reason. Take a note of this. Tell him to watch further and follow him up and send him for an expert opinion as early as possible. It's not easy. I'm trying to not overreact to irritability. Many of us are irritable, but because of situation, and then we get over the irritability in a short time. If this person persists to be irritable, that's abnormal.
Okay, sir. Next question is, why is an acute behavior change likely a complication?
I think acute behavior change means that now the brain is involved out of an extra neurological manifestation of initial disease. Like somebody has fever, somebody has cough, somebody has abdominal pain. But if such an illness starts showing an early symptom of a brain affection, and I want to stress this, that an acute behavior change in any acute illness indicates the brain is involved. Often in such situation, the brain is not involved because the cause of the disease is spreading somewhere else to the brain, but it is due to an non-infective complication like hypoperfusion, hypoxia, immune-mediated or a metabolic changes that are occurring. And that is important. Friends, it could kill the person within next 24 hours if you don't pick up. That's important. And I think that's why acute change, behavior change in an acute illness is a sign of a complication.
The next question is, can abnormal behavior present with physical symptoms?
Yes, sometimes yes. Okay, because physical symptoms like unexplained abdominal pain, recurrent abdominal pain, recurrent headache, feeling weak for no reason, but getting better again in between, could be totally a functional disorder coming out of stress, coming out of anxiety, looks normal. How do you pick it up? When I see a patient with such recurrent symptoms, sir, he has got a recurrent abdominal pain for the last several months. We have done all the tests. A simple question that is asked: when does the pain come? It never comes when he is happy. It never comes when he's with his friends. He is always fine when he is busy playing or he's busy with some entertainment or if he's happy with eating something, but it comes only at the time of convenience. That is a clue to such physical symptoms being of a non physical illness, and that is a behavioral illness, anxiety illness, stress induced illness. And I think it's not difficult. And as a senior pediatrician, I see every week or every month, few times, a child with recurrent abdominal pain thoroughly investigated with endoscopy, CT, MRI, everything. And one question asked: when does this occur? It occurs at the time of his convenience, and at other times it doesn't happen. It does not upset his sleep. It's not upset his appetite. He has not lost weight. There are many clues to know that this is a functional disorder coming out of anxiety, stress, whatever, and that needs to be analyzed further.
As we are coming close to the end of the session, let us take just one last question.
Yes.
As many questions are trickling in, and we can have them answered in our next print edition of GP Clinics. So the last question is, can we examine the mind of the patient?
Oh, yes. I think that's what psychiatrists do. Now, we have never learned where the mind is. We have never learned how to evaluate the mind. We have never learned how the mind works. And that's the pity of a Western medical training. Ayurveda, which talks about science of life, whereas an allopathy and a Western medicine has trained us on science of disease, but not science of health and not science of life. Therefore, we have missed understanding what the mind is. Well, science may not be sure where the mind is located. It's a hypothetical organ, but it does exist. After all, God is hypothetical, but it exists. You call it by one name or another. So now the question is how to address the mind. Friends, I'll give you a simple example. If somebody gives you a gift wrapped up on your birthday and asks you to guess what is inside the gift box without opening the gift, what do? You see the weight of the gift and you guess whether it's light or heavy. You try to smell whether there is anything smell that can give you a clue. You try to move the gift packet and see whether a thing inside is moving. And these are the ways you try to guess. What could a guest of mine give me at my age a gift for my birthday? Well, you can guess. It may not be 100% right. Mind is to be guessed that way. And finally, in day-to-day practice, every physician should address the mind of a sick patient. What does it mean? In his mind, in the mind of a patient, there is a fear, there is a guilt feeling, there is a feeling of something that I have done wrong. There is a feeling, why me? Why not others? But he does not come out of this. When I see a 3-year-old child with COVID proved by test, I must understand what the mother must be feeling. Means I must address the mind. The mother is not bothered what you diagnose or what you treat. She is worried about, doctor, if this is COVID, will my child get worse and get hospitalized in an ICU? Will he come out of ICU? Would he need a ventilation in ICU? That's her fear. And one step further, the fear is, did I do anything wrong to my child that my child develops such complication? This fear needs to be addressed, even by you and me. And how do you address it? You address it by good communication and counseling. I tell this mother, without her asking, Madam, don't worry, this is COVID, but luckily children do not develop any complication. They get better. You must have seen that all those COVID patients who get into the ICU are middle-aged adults or a very senior adults. They are not children. And therefore, don't worry. Those who have got some comorbid pathology like diabetes, hypertension, obesity, whatnot, are the ones who will get in ICU. Children don't have any of this. So, madam, don't worry. He will be completely all right without treatment. I have addressed the mind of the mother. I think this is the duty of every physician also. Don't we? Forget this, but I learned it from my teacher 60 years ago. Unfortunately, the present generation of teachers treat science but not the art. And the art of medical practice is to treat the mind. That's how mind also can be evaluated and treated.
So with this, we end this program here. So thank you, Dr. Ambekar, for this wonderful session. We hope this interactive session would have made learning interesting for attending doctors to help empower their practice.
Sure.
On behalf of Clinics India, doctorslive.com and GP Clinics, I thank all the doctors who have attended this session. Please note the date of the next webinar. It will be 15th of September, because 15th of August being a holiday and many people may not be willing to attend. So we have kept it deliberately on 15th of September, 2024, Sunday, 11 a.m. So the topic would be clinical approach to limping gait. Thank you once again, all of you. Good day.
Thank you, friends. Thank you, Anupam. Let's meet after another